All right. So, sounds so loud today. Welcome, welcome, welcome. We are in week 9. Yay. Which means we have only 2 weeks left. Now, I've been checking the grades, and again, you guys have been doing so good in micro, like I'm taken back. So, if there's anything that you guys have questions about tomorrow, just let me know. Today we have I know some tough subjects in 200. So, we are going to be talking about psychosocial needs of the patient. But in chapter 14, we are talking about death and dying. So, today is one of those live sessions where it's a little bit different. If that topic is just too much for you, I totally understand. Just make sure that you go ahead and read your chapters. And then if you have any questions, let me know. Okay. Because it's not an easy subject, I should say. It is kind of tough. And one of the things that we don't ever want in the operating room is to lose a patient. And for me, the first time it happens, for me, I'll never forget. So, although it's rare, unfortunately, it can happen. Okay. Now, with that, let's get into our quote of the week. Keep your face always towards the sunshine, and shadows will fall behind you. And that is by Walt Whitman. Now, it reminds us that focusing on the positive and kind of staying determined, we can overcome any challenges, any setbacks. Okay. Our field is very demanding. I'm not going to sugarcoat it. There are times, like I mentioned, that you are very humbled by the fact that you're able to kind of just be with a patient. Um, and for me, my first case happened to be where we were actually harvesting organs, and I had to remind myself that, like, we did lose this patient. However, we were able to kind of help 7 other patients. Okay. It's like mental gymnastics that we do. Um, but I want you guys to continue to focus on your goals, your progress. The difficulties are going to become less overwhelming. It's not going to like change and be like, oh my gosh, I can handle it all. Right. But you'll have a different perspective. Just like the sunlight outshines shadows, your dedication and perseverance is actually going to help you rise above those obstacles that are going to come your way. So keep moving forward and remember that every challenge is an actual opportunity for growth. Okay, kind of went through that really quick. So, we are going to support the psychosocial needs of the patient. Now, our learning objectives. We have to talk about patient centered and outcome centered care. So, for so long, when it came to the healthcare system, we were really concentrating on um, services and getting the patient in, getting the patient out, right? But as we all know, every patient is different. You can do, let's say we're all scheduled to do an appendectomy, right? And we've worked with a certain doctor and we've did this particular case 1,000 times. And so we know exactly what he needs and what needs to be done and how we're going to go through the procedure, right? But with patient-centered care, you can have 10 different patients doing the exact same case, and you're going to do it differently each and every single time. Now, the steps may be the same, but there's different factors: the patient's age, the patient's weight. Let's say you have a healthier patient versus a patient that has a lot of comorbidities. You have one that is pretty healthy versus one that, is coming in with congestive heart failure. So, yeah, you've done an appendectomy with, say, Dr. Smith 20,000 times, but each time is a little bit different. And so we get into the actual patient centered care. Okay. We're going to talk about the basic human needs as described in Maslow's hierarchy and Rogers' humanistic theory. Now, with this one, I have seen questions on both the CST. It's going to come around again in module 3. You're going to see it in module 4, and especially as you get closer and closer to taking the actual CST exam. We are going to look at what we need to feel safe, right? Like, what are some things that we require for safety? We're going to talk about patients' fears because that is real. There are fears where, for us being in the operating room, we're like, we don't become numb, but we do it so often that sometimes we forget that, like, someone being afraid to wake up, that's a real fear, right? And for us, trust me, once you get there, you'll know. We're so used to patient being intubated, patient being extubated, they're waking up. Like, we know the routine, but we always have to try to put ourselves in the patient's shoes and think, okay, but let's say they don't know anything about medical. Okay. And then we are going to look at just special needs. We have to talk about perioperative care and define spirituality as it applies to patient care. So we break it down, right? Our job as STs is not just technical. Yes, we're in the operating room, we're helping with suturing, retraction, visualization, but it's also about providing care that meets the patient's unique needs. Now, here's how we kind of figure out what those needs are. The chart is going to be big. The history, allergies, medications, past surgeries, that's going to be able to spot for us to spot any risks or special needs that may occur during our procedure. Okay. Now, for me, believe it or not, I'm an actual introvert. I know I am actually an introvert. So I got into this field because a lot of times I'm not going to be talking to my patient. Like, this is perfect because they're usually asleep. But there are times when we do have to communicate with the patient or the patient's family. If you have the chance, you may ask if they're nervous or have any cultural or personal needs or any other outcomes. You're probably sitting here going, when would I be talking to a patient? Haha. Let's say you're a runner. Okay. And so me and Mark are runners that day. Okay. Meaning that we're not necessarily assigned to a room, but we're going to be giving like Jessica L a break. We're going to be giving Blanca a break. We're going to be giving Nadawan a break. Okay. But in between our breaks, we may be escorting a patient family member to and from the operating room. And a lot of times, they're going to be usually nervous, they may be concerned because, again, some of our patients, when they come to the operating room, it's on their worst day. Like, something bad has happened. They're coming in for surgery and they've got to get it fixed. Okay. Unless it's like elective, but a lot of times, especially bigger hospitals, they're coming in because something is wrong. Okay. Now, we also check in with our surgeon and our anesthesiologist. Um, our nurses or our circulators, we're gonna all need to know what's going on with that procedure, what instruments, what positioning. Now, it's on the surgeon's preference card that we're going to break down in module 3, but these are some things I kind of want you to start looking at. We can notice body language when a patient is coming in and they're either walked in, they're on a gurney, or even in a wheelchair. Are they fidgeting? Are they avoiding eye contact? They may show like they're worried or in pain by just slight movements. We think about, again, the patient's age, the patient's size, their mobility. That might affect how we prepare our surgical space and making sure that we have appropriate tools and instruments. For example, a neonatal patient, meaning a patient from 1 second old to, let's even say, a 1 month. Okay. 1 second to 1 month. They are going to need instruments that are a lot more delicate, a lot smaller than, let's say, our quarterback, 6'5", 230 lean patient. Doing the same case, but I guarantee you that neonatal patient is going to have a lot finer, delicate instruments because of the tissue. Okay. Now, doing all of this helps us to create that safe, more comfortable surgical experience that we want our patients to have. Now, again, I have seen many questions on different exams on Maslow's hierarchy. Now, Abraham Maslow, he was a psychologist who developed the theory of like our motivation. And that's why it's known as Maslow's hierarchy of needs. He focused on really understanding what drives us as humans, like our behavior as individuals and how we achieve like our personal growth and fulfillment. Now, the most basic needs, like we're talking about down here, the basic needs, okay? This is the foundation. These are our psychological needs: breathing, eating, drinking, sleeping. Without these, survival is just not possible. Now, the triangle itself, because I often get like, why a triangle though? The most critical needs, the ones you need for survival, are going to be the base, like that foundation. They're the root. Okay. As we start to move up, the needs become more related to our emotional well being, our social, our spiritual fulfillment. The shape itself highlights the foundation importance. Higher levels can only be achieved once the lower levels have been met. I will repeat this. Higher levels can only be achieved once the lower levels have been met. Okay. Now, Eckerson's psychosocial theory is a little different. It occurs in 8 stages, each with, let's say, a core conflict. Okay. Now, it does build on the last stage and it shapes personality and our emotional resistance. For us, we need to understand that these stages, they're not just theory. It provides, I would say, like a practical lens to kind of now we are going to anticipate how patients at different ages may respond to stress, hospitalization, and for us, which is really important, surgery. So we get into autonomy versus shame and doubt. And we look at ages between 1 to 3. Okay. Now, toddlers in this stage, they strive for independence, feeding themselves, choosing their toys, and trying to dress themselves. When encouraged, they develop autonomy, which is that like sense of confidence and like, hey, I was able to pick out my toy and put the little circle in the circle spot. Okay. The positive outcomes of this stage is willpower. Now, the strength to act with intention while respecting their limits. For us, pediatric patients, if you ever get to do peds, it's a little bit different, a different world, okay? Especially with toddlers. They may display resistance or fears in pre-op and recovery. A lot of times we do what's called patient or parent induction, where we'll bring the toddler back with their parents and hopefully, because a lot of times the parents are a little bit more stressed than the child. But a lot of times the parent can kind of like put the toddler and the baby at ease, and that helps. Okay. Their need for control and independence is actually being challenged by being in a hospital. They may not even understand what's going on. Even adult patients may regress under stress, showing like childlike needs or reinsurance that they need, um, choice, and even validation. For us, being able to recognize when patients may be stuck developmentally under stress, we'll be able to like kind of adjust our interactions. That way we can provide better psychosocial support. So let's break down those psychological domains. We help protect the body's basic life functions. Okay. These are called physical domains. The body's basic life functions are called psychologic domains. They are the top priority in surgery because they keep the patient alive and stable. Respiration, getting that oxygen in the body. Nutrition. Some patients are going to come to us with fluids already attached. They may have special dietary needs before or after surgery just to help their body heal. Blood must flow properly. And that's to help deliver oxygen and nutrients to and from the different organs, which means our anesthesiologists, our CRNAs, they're going to be monitoring that extremely close. The body also has to get rid of waste like urine. So, a lot of times, especially if you're doing a longer case, just know that you may need to be, or you may need to assist with providing the catheter for your circulator. Not saying that you're going to be doing it, but they may put it on your field sterilely where you'll assist them to put the catheter in, meaning handing them what they need. Okay. Reproductive health is another one. Surgeries involving our reproductive organs, we're trying to protect the patient's reproductive health and all function. A lot of times when we do a lot of X-laps on younger childbearing females, we'll see maybe an ovary that's twisted, and we're going to do everything we can to really preserve the reproductive organs. Okay, we're going to try to do everything we can so that it can flow properly without trying to remove it, especially in children. Talking about growth, they're growing. Children must have the support for normal growth and development. And then when we talk about repairing, we play a role in preventing infection. That's one of our biggest things. The very first 3 weeks of module 3, we're breaking down sterilization and decontamination and what can happen to our patients if one of those measly little microbes that we're learning in microbiology do infect the bone, the blood, different organs, and movement. If a patient is not properly positioned, they can be injured. Their nerve damage could happen. And we're trying to support the patient's ability to kind of get back to some type of mobility after surgery. But that's not it. Okay. Our patients want to feel safe and secure. That's so important. So, we proper position. So you heard that twice already. That is going to be really big. Okay. Once you guys get in the lab and you start positioning patients, we're going to show you the mechanisms to make sure that our patients are positioned in a way that they're not going to get ulcers, they're not going to have nerve damage, and we're going to preserve everything we possibly can. We're trying to prevent infection. We have strict sterile aseptic technique. They're going to be continuously monitored. Their vital signs, their respiration, their oxygen, their urine. We do in and outs. Whatever comes into the body, our circulator's checking to make sure that urine is actually coming out. We're also checking to see how much blood is coming out with the suction and our sponges that you're going to learn about in module 3. Now, psychological needs like fear, anxiety can significantly impact the patient and their family. For example, fear of anesthesia. Patients may like worry about just waking up during surgery or not waking up at all. That can be very stressful. We're going to be talking about death in the next half of this live session. Facing a life-threatening condition or a high-risk procedure can lead to emotional distress for both the patient and their family. There's a fear of postoperative pain, believe it or not, and that can increase tension, making the patient that much more less cooperative or even more difficult to calm. Disfigurement is another one. Loss of control, not being able to do the things that they did before. Prime example. Let's say a patient is going in after a motor vehicle accident and they had bilateral crushing limbs, both their lower extremities and their upper extremities. They went to sleep whole and now they woke up a quadruple amputee, right? Think about how they're going to be feeling and what they're going to be going through. But it's not just them. Families may feel helpless. Like, what do I do? My son or daughter just lost all 4 of their extremities in a motor vehicle accident. We're happy they're here, but they've got a long road ahead of them. There's that overwhelming feeling of seeing a loved one in distress or facing a very prolonged recovery, especially when you want to help them, but there's really nothing that you physically can do at the moment. But that's not it. We get social domains. Now, for us, our main focus is on the procedure, right? But it's still important to understand emotional factors like family support, body image can all help us to be a better support for the patient's overall recovery. You never know. It could be that small glance you give a patient before they are intubated that just puts them to calm. Okay. Now, family can play a huge role in how a patient heals. Having loved ones nearby, it does help reduce stress, fear, loneliness, especially before and after surgery. They can motivate the patient. Okay. It helps the patients kind of stay positive and really stick to recovery plans. There's the practical help, right? Transportation, medication administration, wound care at home, which is really big. So we look at body image because I talked about the dismemberment, or not dismemberment, but the double amputee or quadruple amputee. Body image is how we view our own appearance, how we think others see us. Surgery, especially if it changes how someone looks, is going to affect their self esteem. Now, even though we're not making the decision about the surgery, we can help handling the tissue gently because we're trying to reduce scarring. There's going to be many a times where me and Sierra may be scrubbed in and the surgeon is like, Sierra, I need you to hold the tissue. And the surgeon gives her some forceps. You guys are going to learn in week 4 of module 3, some forceps to gently retract the skin for visualization. We also have to be aware of what parts of the body are visible. We support a respectful and caring environment. Like we're always trying to be there for our patients. And sometimes it's just, how would I feel if I was that patient? Now, every patient reacts to surgery differently. Things like culture, past experience, age, personality, it's going to affect how we cope. Okay. But we are in a very unique position to support the patients emotionally, even if we are not directly providing care after surgery. So we pay attention to how the patient acts. We look at verbal cues. Do they ask a lot of questions or do they seem confused? We look at nonverbal. Are they fidgeting again? Are they like not looking at us in our eyes? Are they just looking very anxious? We try to be mindful. Different views of pain, privacy, or how families may make medical decisions. Needs like modesty, religious restrictions, or language barriers are things that we have to kind of think about. There are cases where certain religions will not allow blood or blood products to be entered into a body. That brings up ethical and other emotional on our side because we want our patients to get better, but we also have to respect their beliefs. We also have to understand what makes each patient unique. Again, a bad surgical experience can make someone just that much more scared or fearful. Kids in general might fear being away from their parents. Older adults may worry about just losing that independence. Knowledge is another one. Of course, we have a larger vocabulary and we know different medical terms, but informed patients often will feel more comfortable and less afraid. But the reverse can happen as well. If a patient just doesn't really understand what's going on, that brings on a whole nother set of emotions. So, what do? We can offer calm, reassurance, show empathy. A lot of times it's going to be that eye contact we make with our mask, our goggles. We're looking at the patient, and the patient's like looking at us. Trust me, it happens. Okay. We help ensure the patient understands what will happen if we are in those situations. A lot of times, all of that is going to be with our circulator, our surgeons, our CRNAs, or our anesthesia provider. But we're going to work as a team. We're trying to reduce stress. For example, sometimes we will be a little bit more quiet, especially if we know our patient's a lot more anxious. We're going to be respectful with what we're doing because a lot of things happen simultaneously. You're setting up your field, patient's coming into the room, anesthesia's getting ready to set up their stuff to intubate. The nurse is getting everything ready to do the IV. The surgeon's doing whatever the surgeon's doing. So there's a lot of moving parts happening simultaneously. But by staying alert and compassionate, you're actually helping the patient feel safer. And you're putting them a little bit more at ease. But there's also that therapeutic communication. It's talking to a patient in a way that builds trust. It makes them feel safe. We're not talking down to them. We're not making them feel less than, but we're just kind of meeting them where they're at. Now, even though, again, our main role isn't the therapeutic talk or communication, how we communicate can affect a patient's comfort and confidence before surgery. You got to remember, until they're put to sleep, and sometimes there have been patients that said they could hear everything that was going on in the operating room, they're listening. They're almost hypersensitive to what's going on around them. So we let the patient talk. We don't interrupt. If a patient says they're scared of anesthesia, if you're in the situation, you may respond with, I hear your concern. The anesthesia team is going to monitor you closely. The goal is going to make sure we keep you safe. We're going to stay focused. We're going to help anxious patients by staying on track. Like if they get off topic by saying a whole lot of different things, you'll say maybe those are really good questions. But right now, let's talk about today's procedure. You let them know that their feelings are normal. It's understandable to worry about, let's say, scarring, but we are going to take every step to minimize it. Our body language matters. We're going to make sure that we make eye contact. We're going to make sure when we're hearing them, we're nodding, we're showing that we're listening. And we're going to keep like an open posture because we want to show that we're listening. We go back all the way to week one when we talked about body language, right? If we're standing there and the patient's talking, we got our arms crossed, we're not really looking at them, that's going to really add to their already anxiety that they may have. We can ask for details for more support. You mentioned you're nervous. Can you tell me more about what's worrying you? Granted, most likely we're not going to be in these situations, but those few times where we are walking a patient to the operating room, walking a family back to recovery or PACU, we could be in those situations. The biggest thing is never promise anything. Never, ever, ever promise, you know what? They're going to be healed because we don't know. Yes, we're going to do the best we can to take care of you, the patient, but we don't want to promise something. Okay. Now, we're focusing on the patient. We're giving them our full attention. We're validating how they feel. For example, the patient's like, I'm scared. We can say, again, it's completely normal to feel that way. Let's talk about what to expect and how we'll keep you safe. Now, mind you, it may be, let's say they're walking, because a lot of times we have patients walking to the operating room. It may be a 2-minute walk, but a lot can be said and felt in 2 minutes, especially from a patient's point of view. Okay. Again, like you say, we're providing information, but we're not going to say we're going to start at the right lower quadrant with a fan and steel incision using. We're not going to go into that detail because they're going to be like, "Whoa, what?" And what I just showed, what I was saying was the location of an appendectomy with the type of incision and the knife blade with the handle. They don't want to know all that, right? So we kind of just let them know you're in good hands. We are highly skilled and we're prepared for your procedure. That's also giving reassurance and providing clarification. Now, for us, patients often communicate their fears and anxieties in subtle ways. Their tone of voice, their body language, or maybe they're just a little bit nervous to talk. A lot of times in the operating room, you're going to have your back table set up, your Mayo stand ready, and you're going to actually be broken scrub, meaning that you're going to become sterile. So you'll still have on your hair cover, kind of like this individual, this tech. Hair cover's on, mask is on. A lot of times I keep my goggles on, but his back table I can guarantee you it's set up and ready to go. A lot of times we'll be asked to help move a patient from the gurney to the OR bed. Now, patients are going to be able to communicate those fears, right? If a patient repeatedly is asking the same question, they may not need more information, y'all. They may just need reassurance that I hear you. It's okay. Okay. They want to know they're being heard. We are not just hands on with instruments, we're also the eyes and ears of the surgical team, especially for those psychosocial needs. Active listening means that we're doing more than just hearing them. It means that we're showing the patient that their feelings matter. Simple strategies: repeat back what they say in our own words. We're always going to maintain eye support or eye contact. We're going to avoid multitasking during their interaction, which is going to be hard, I promise you, because multitasking is what we do, right? I could be talking to Sandra because you're right in front of me and doing something else and hearing everything that she said. She may not think so. Sandra might be like, "Are you listening?" And then I'll stop and repeat everything back because that's what we do. We are good at multitasking. Sometimes we have to step out if we are in a situation where we're with a patient. Okay. Avoid false reassurance. That's the one thing that I was mentioning earlier. Saying everything's going to be fine can feel dismissive for a patient. And it actually can increase anxiety, especially if the patient senses a little bit of uncertainty. Instead, we focus on honesty and presence. Again, you're in good hands. Our team is here for you. This is going to maintain that trust without kind of like giving them the world per se. Okay. And we look at anything that's unusual, we're going to speak up. Sudden emotional withdrawal. Let's say we're noticing the patient's a little bit agitated. We're going to communicate directly to our circulator, our surgeon. If it's just you and anesthesia in the room, a lot of times it's us, they're doing their thing, I'm setting up. We're going to communicate. Think of yourself as the bridge of communication between the patient and the surgical team. Remember, we are that patient's advocate. Now, we have to differentiate between empathy and sympathy, two different things. Empathy is putting yourself in the patient's shoes, feeling feeling with them, I should say, showing your understanding without kind of judging them. Sympathy is feeling pity or sorrow for them, which can actually create that distance rather than a connection. Make sure you're able to differentiate empathy and sympathy. Patients want to have a sense of partnership, not pity. And then we're going to reinforce different things. Our interaction with patients at moments of extreme vulnerability. Again, they're coming on some of their worst days. So we're trying to build that trust. We're trying to show patient-centered care, and that's going to elevate our role beyond our technical skills. We become that essential part of the patient's safety and emotional well-being. Spiritual needs is another one, especially the chapter kind of highlights. And the very first thing that I want you to notice, that very first sentence, not necessarily religion. Spiritual needs goes beyond religion. It involves into a person's sense of just meaning, purpose, connection to something that's greater than themselves. In our setting, for example, it's important to just acknowledge that these needs are important to provide holistic care. Example, a patient may not be religious, but may find comfort in meditation or reflection. Spirituality often involves a deep sense of purpose, connection to the universe, humanity, or even a higher power. A patient might express a belief that everything happens for a reason, which provides them that kind of peace and hope during the recovery, which is so important. Spiritual experience itself is often internal and it may not be observable through physical signs. Like we may not be able to see it. For example, A patient may experience a sense of just like a calmness or a comfort through prayer or quiet, quiet meditation, even if it's not visible to everyone around them. Many people find strength in belief in God, a higher power, a spiritual entity, which may guide them through the illness and their recovery. Now, for us, it's so important to just recognize and respect the spiritual needs of our patients because that's going to help them overall with support and it's going to help create a more compassionate and holistic approach to care. Now, how do we handle religious and spiritual items? This is big. You may see a question on this, hint, hint. Now, patients may actually request to kind of bring in personal or religious items like the rosary, prayer beads. Items must be removed after the patient is asleep. So we're not getting them in the room and start yanking stuff out. We don't do that, okay? Because we're very respectful. But items have to be removed because remember, some of these things can have like metal in them that could kind of mess up with different things that we're doing depending on the surgical procedure. So it's removed after they're asleep, it's labeled, and then we securely place it or we store it. We make sure that we respect beliefs while maintaining sterility and safety is so important. And that's why we're removing them. Okay. But it's going to be labeled, it's going to have their name on it. Most likely, it's going to be placed with the surgeon or the patient's belongings. There's a patient belonging bag that comes with them. Okay. Now, surgery is not only, again, a physical experience, but also an emotional and spiritual event for a lot of different patients. And so they may require for their own beliefs to come into the operating room with these items on. But again, for safety, we have to kind of remove them. Okay. And that's all going to be protocol. Now, with our special patient population, each population has unique needs that require careful attention and adapted communication techniques. So we have our patients that are disoriented. These patients may be confused, they may be forgetful, they may be just unaware of where they are. Like, where am I? Who am I? Okay. They may experience disorientation because of their illness, because of their medication, or depending on the surgical procedure that they had. So the chapter talks about different communication tips. Make sure that you really hone in on that because that's really important. Not just for our disoriented, but for our pediatric, our older, and our patients with developmental disabilities. Now, the last part before we get into the deeper subject is there are some patients that have certain considerations like diabetes mellitus, those with that are at risk of hypothermia or poor circulation. Now, with diabetes, it often affects small blood vessels. Okay, these are your microvascular diseases we're talking about, leading to very poor circulation in extremities. Poor circulation means less blood flow, slower healing, and greater risk of skin breakdown. Patients with diabetes also lose body heat more quickly under anesthesia. That's really important to know. We're going to be paying attention. We keep our patients warm. So, one of the first things that happen once the patient comes in the room, remember, things are happening simultaneously. We're setting up our back table, patients coming in the room, circulator or a runner is going to go grab a warm blanket. We tend to keep blankets in our warmer that we keep our warm fluids in as well. That way, if need be, we'll grab a warm blanket and place that onto the patient. Okay, keeps them warm. Um, we're positioning them to protect skin and maintain circulation. We also put on anti-embolytic stockings and circulation support, especially for our patients that are in longer cases, compression stockings, pretty much. But we also connect them to a machine that kind of massages their legs and gets the blood flow. Because remember, if the patient is we're in a 12-hour case. Okay. Patient's not moving for 12 plus hours. So we want to make sure that that blood flow is still getting to those extremities. Now, in diabetic patients, stockings help improve venous return and reduce complication. Um, so the stockings, and they're the long white ones. They come in different sizes. We put them a lot in orthopedic cases as well, especially if we know that we're doing a longer case, um, especially in cardiovascular, neuro. Those are going to be the ones that they're going to already have them on, or sometimes we'll put them on in the operating room. We're going to be monitoring blood glucose levels because it can spike. And that's because surgical stress response. Or it can plummet because they've been fasting and medication. Because remember, they're nothing by mouth after 12 usually. So then they've been fasting. Now, both high and low blood pressure or blood sugar can delay healing, and both can cause risks. Now, we do not administer insulin. Just want you guys to know that. But we are a part of the safety net team. So we're noticing symptoms of hypoglycemia or hyperglycemia. And then, of course, we're all talking and we're like, hey, I'm noticing this. Now, granted, for us, 9 times out of 10, it's going to be as the patient is being put to sleep. Because once the patient's with the drapes and everything on them, you do not see anything. You don't see any of this. A drape is covering their face. And the only thing that we have visualization of is the actual site where we're doing surgery. Okay. There are times when there are higher risks for infection, like the patients with diabetes. A lot of times, if I'm in a trauma case on the evening, and depending on, let's say I'm doing a thrombectomy, and I know that the patient is diabetic and they've already had, let's say, a bilateral, a below the knee amputee on the other side, in my mind, I'm thinking if we don't get the blood flow back to this other leg, then 9 times out of 10, I'm not just doing a thrombectomy where I'm trying to get the blood clot out. I'm also preparing for an amputation. So these are different things that you're already thinking about as you're setting up for certain cases, especially when you know the history. Okay. Now, again, kind of got there. And for those of you, this is going to be the tougher of the two lessons. I think this is one of the toughest lessons for our course. We're getting into death and dying. So if at some point this just gets too much, you have to walk away, grab a glass of water, and when you are more comfortable, come back. Okay. Now, we have to talk about the end of life period and brain death. We're going to talk about Kubler-Ross's stages of dying. We're going to talk about support of the patients in the dying period. We also have to look at conflicts and stress families face during this period, look at ethical issues surrounding death and dying, and look at cultural competence, discuss concepts of determination of death and the physical changes that happen in the body. We're going to talk about corner cases because they're a little bit unique. And organ recovery. You can be either on the donor team or the recipient team. For me, I've only been on the donor team, so I can't really speak on recipient teams. But I know that theirs is just as humbling because they're receiving organs from a patient that was recently deceased. For me, on my side, it's when we are trying to save these organs to save a couple more patients. Okay. So let's get introduced. And you'll notice that tonight's not a lot of questions. So if you guys do have some questions, go ahead and ask them. Okay. I do this one just a little bit different just because of the nature. Now, during death, surgery is rare. Thank goodness, right? But it can happen. We have to be prepared to respond with care, respect, and professionalism. We support both the technical and the emotional needs in these moments. So we have to think of a couple things. Okay. Families experience shock, grief, confusion. It's important that you're responding with compassion. We also have to respect the difference in cultures that handle death in unique ways. Some expect certain rituals or prayers. Some patients have specific wishes or fears about death. These may be based on religion or personal experience. So we listen and we show empathy when appropriate. Understanding a patient's view of death really helps us, or helps them, I should say, feel safer before they even go into surgery. End of life choices puts things into ethical perspectives. There may be tough questions about whether to continue or to stop life saving measures. That happens on those rare occasions in the operating room. We have to respect the patient's or the family's wishes, even if we're like, let's just try one more thing. It is so important to know if a patient has a do not resuscitate order before surgery so their wishes are actually honored. And then there's the legal perspective, okay? Because remember, the medical record is a legal document. Every detail leading to a patient's death must be written down clearly and accurately. Some deaths may legally require an autopsy. So we're going to have to follow the hospital's procedures, whatever the procedure may be. I want you to think of this. We have to look at the cause of death. We have to understand whether death was caused by the surgery, a medical condition, or something completely different. After death, the body must be treated with dignity and handled according to whatever the hospital rules are. Now, end of life care begins when a patient is expected to die within days, and treatments meant to cure or to extend life are no longer effective. At this point, the focus shifts to comfort, dignity, and emotional support for both the patient and their family. Now, there's a lot of different views on end of life. There's the medical view. When treatment stops working, doctors focus on comfort. That is palliative care. You may do palliative surgeries, and that is tough, but you may be doing it. I did not too long ago, a craniotomy, and it was palliative. We were trying to give this family just a little bit more time with their little one. It was palliative. Okay. It happens. We're not trying to cure the illness. We're trying to focus on comfort. Okay. There's a social view. Family and friends may need help coping with grief and the reality of just losing someone that they love. Then the ethical view. Patients have the right to choose how they want to die. This includes a DNR, do not resuscitate, or even other preferences. We cannot forget the spiritual view. Some people may want religious or spiritual support, like prayer or last rites, and that's going to depend on their beliefs. For the patient, we can help by being respectful, by being calm, by comforting them, helping them manage the pain and preserve their dignity. For the family, we're trying to keep them informed, listen to their concerns, and show empathy, not sympathy. This is often confusing, especially if it's an unexpected, right? When death is expected, again, we recognize that death will likely happen, and that allows time to prepare emotionally and practically. Once it's clear treatment won't help, CPR, ventilators, aggressive medication is often stopped. This is done because we're trying to avoid unnecessary suffering. A lot of times our surgeon will call it and we stop. Now, even without life-saving treatment, care doesn't stop. Like, we're not going to be like, all right, you guys, we're out. Pain relief, emotional support, and spiritual care, if requested, are provided to those patients so they can pass with dignity. We look at cause of death. The cause of death is the specific reason or underlying condition that led to a person's death. It's determined through medical evaluation and classified per the book by the Center of Disease Control and Prevention using the IDC. So that's the International Classification of Diseases, and it's a whole system. The system provides standardized codes for all medical conditions and causes of death. Why is this important? The cause of death is required for coding medical cases, and it's really important for record keeping, basically. They also look at statistical analysis and public health planning. We look at the models of death and dying. So the first one we're going to talk about is Kubler-Ross. Okay. He explains it in 5 common emotional stages. This is what we pretty much hear all the time. Okay. Denial, this can't be happening. The person may just reject the diagnosis or feel numb. Anger, why me? There's frustration. Um, their blame may be directed at doctors, like, you're wrong, you don't know what you're talking about. Could be to their family or even fate. Bargaining. Let's say, if I could just have one more time, the person may try to make deals with doctors, family, or even higher power. Depression is, well, what's the point now? Sadness sets in. Reality of dying becomes more real. And then acceptance. I'm at peace with this. The person may come to terms with their condition and find calm. Now, not everyone follows these stages. It doesn't go like shock, anger, bargaining, depression, acceptance like that for every person. Some people skip stages or feel them in different orders. They may start off with acceptance and go to depression and then start at anger and go back down to acceptance. Okay, so just keep that in mind. It's not going to be straightforward. Different cultures, they're going to express grief and dying in unique ways. People might feel anger and acceptance actually at the same time. It's not always a step by step process. So that's one thing I want you guys to make sure you understand, because I have seen questions. But more than that, just to know that it's not going to be a straightforward step by step. We're starting with shock or denial and ending with acceptance. Okay. All right. So we look at the dying patient in the operating room. Again, this is rare. When caring for a dying patient in the OR, interactions may be brief, but they are so critical for providing that comfort and maintaining the patient's dignity. Our focus is on addressing the patient's immediate physical and emotional needs with empathy and respect. When a patient dies suddenly, okay, especially in the OR, it's rare, but it is emotionally intense. Our role is to not speak to the family or explain what happened. We're not trying to tell sides, but we still play a vital part in handling the moment with dignity and professionalism. I pray that you guys don't ever have to have a situation, but if you do, I want you to be ready. Um, it, and mind you, I'm a compartmentalist. So for me, I will feel it later. Like, I will take the moment, put it in a room, and lock it up. But I don't leave it there. I make sure that I feel the emotions because it's really important. Okay. So you stay professional, you keep calm, your composure is going to help the rest of the team. Like, you are a team. Everyone handles things differently. Um, I have seen members break down crying and we still had a whole shift left to do, right? People get angry, frustrated, but at the end of the day, we have to still come together because, yes, there's this patient, right? But then we have more patients to come. Now, I'm not saying do like me and just kind of hide it and put it away, but make sure that you are able to kind of find that outlet that works for you. Okay. Because that's really important. I do, usually for me, it's when I'm in the car, before I start my engine, my shifts is over, and then I allow myself to kind of feel everything. Sometimes you're cleaning, you're positioning the patient, make sure you're making sure that the family members are guided to the right people, like surgeons, chaplains, social workers. We help close that operating room depending on the facility. Some facilities, um, where if a patient does die in the operating room, we keep the patient in there. We don't touch it until they are released to the coroner. Some ORs for us, we will move the patient into PACU, and so it will sit with the patient or the body until again coroner takes over. So it just depends on your facility. Again, there's ethical considerations. Patients have the right, right? They have the right to make the decision. DNR, I don't want this. The right to die is encompassing the right to refuse medical treatment, even if it may result in death. The chapter talks about palliative care, where we are focusing on comfort, managing symptoms rather than trying to cure an illness. We're making the dying process just that less painful, and a little bit more dignified. And then with organ donations, this is the decision about organs where typically made by the patient via, like, maybe there's a consent that's done. It can be on their driver's license, like a little organ donor. I have one on my license, or in the absence of a prior consent by the family in accordance with legal and ethical guidelines. We look at a living will. The chapter talks about that. Make sure you know the difference between a living will and then clinical decisions without a living will. Okay. We get cultural competence. It involves just understanding and respecting and adapting to the different beliefs, okay, practices and expectations related to healthcare. In hospitals, especially in the surgical setting, it's so important to understand how death is confirmed and what is respectful postpartum care and how that looks, even if our particular role is limited to supporting the process. Only qualified, and I have seen questions, only qualified healthcare professionals like a doctor can officially declare death. I will repeat that. Only qualified healthcare professionals can officially declare death. Now, after death, the body naturally is going to go through several physical changes. We just have to understand that this helps how we're handling the body. Okay. Of course, we're going to handle with care and we're going to prepare everything respectfully during postpartum procedures. In the operating room, you may, especially if you're doing a harvest or a organ retrieval, with helping close the body and helping with the suturing and helping the team get that body ready. So just keep that in mind. Positioning is going to be big. The chapter breaks down, and you guys can kind of see the list of exactly how we do things: elevating the bed of the head, closing the eyes, closing the jaw, placing pads because things can leak. Okay. Make sure you go back and kind of just go over that. Now, before we get out of here, I do want to kind of touch on the coroner's case really quick and organ recovery. So, a coroner is involved when death occurs under specific circumstances. Hint, hint. Coroner's involved. If something looks suspicious and we're like, wait a minute, coroner's going to come in. Okay. Could be in the operating room, could be in the ED, it could be suspicious or unusual circumstances, like a criminal activity was happened, like a homicide, a suicide, where it's a suicide but doesn't really look like a suicide. They're going to come in. Okay. And with organ recovery, again, it could be on either team. Organ procurement follows hospital and legal procedures. It does require consent. So we're not like, oh, this person, let's go ahead and take their stuff. We're not doing that. Only patients who meet specific medical criteria can qualify for organ donation. So keep that in mind. What questions do you have for me? And also, I just want to thank you guys for sticking with us. I know that these two, death and dying, can be tough. And so I try not to make it so I'm asking you all these questions because these are pretty tough subjects. But with that, what questions do you have for me? No questions. How it depends. So great question. How long do we have to harvest? It depends on whether you have a heart beating cadaver or a non-heart beating cadaver. What I mean by that is if a patient um true this and this really does happen. Let's say a patient is considered brain dead. They hung themselves. Okay. We actually had a patient and they were intubated, which means that they may not have had brain function, but we had time because all of the organs were still being perfused, like, machine was controlling it. And then for those with a non-heart, non-beating cadaver, what normally happens is, and I can only speak from like experience, so you have to look at the facility. We had an hour from the time the heart stopped to bring the patient to the operating room and cool down the body. So pretty much an hour to cool down the body. And then once we got the ice on the body, we could breathe a little bit and then we started to procure organs. Does that kind of help make it make sense? Because it's really too tight. Like if the patient has a heartbeat, the patient doesn't have a heartbeat. So I saw positions for surgical tech police department. Is that more homicide studies? Not interested in doing that. Just curious. I like how you said that. Not interested. It's really going to depend. You can definitely do that. We have so many places that you can work. So you can definitely, that is one route. You can definitely go into like forensics where you're constantly in that type of world. Um, it's not my cup of tea. So, but definitely another option. All right, you guys. This was tough. I do want to thank y'all for sticking it out. Um, Tomorrow's gonna be not tomorrow. Next week and tomorrow is gonna be a lot lighter. Okay. For those of you that are watching this playback, how can a patient's cultural belief affect their end of life care? What patients When patients can't express their wishes, what should kind of guide decisions about organ donation? And how can healthcare professionals balance comfort and professionalism when caring for a patient that is dying? Quote of the week: keep your face always towards the sunshine, and shadows will fall behind you. Thank you. This one's always a tough one. So, again, I'm very humble, but you guys have a wonderful evening, and I will see you guys tomorrow. Thank you. Thank you.